Just in case something goes wrong, do you mind if I put you on the phone?
You're on, Daphne.
I can check out. Sorry, thank you. I appreciate that.
Diana, go.
Okay, welcome everyone to our virtual symposium titled Cardiobstetrics Around the World. My name is Diana Wolf. I'm a maternal fetal medicine subspecialist here in the Bronx, New York, where I practice high-risk obstetrics at Montefiore Medical Center. I work with a team of cardiologists here at Albert Einstein College of Medicine. We call ourselves the MFM Cardiology Joint Program. And today I would like to acknowledge and honor one of our team members, Dr. Cynthia Taub, who will embark on a new journey as chair of cardiovascular medicine at Dartmouth College. We thank her for all her contributions to our patients and to the field of cardiobstetrics in general. Thank you, Cynthia. So for today, participants feel free to write any comments and questions in your chat. We will do our very best to address all. I will be the timekeeper and make gentle time warnings if we're going over. We have quite a journey today. We're going to begin our flight in Southern California with our first keynote speaker, who will talk about cardiobstetrics from the MFM perspective. And then we'll go over to Toronto, Canada for our cardiology perspective of cardiobstetrics. And then we're going to take a very long flight. We may have to stop on the way to Kigali, Rwanda for our first case presentation. And then we will go back west to Milano, Italia for our second case. And then we're going to, again, take a long flight, put on your compression stockings to South America, to Medellin, Colombia, for our last case presentation. So everyone, fasten your seatbelts and let's get started. I would like to present our first speaker, my most respected colleague and friend, Dr. Afshan Hamid, who is very unique. She's the only person I know who is board certified in OBGYN, maternal fetal medicine, and cardiology. And this really gives her a very unique knowledge foundation and perspective of experience when talking about cardiobstetrics. She is a key player in several national and international organizations where bundles and protocols are in process in being made in this evolving field. So we're very, very gratified to have her join us today. Thank you so much, Afshan, for joining, and I will hand over the microphone to you. Welcome, everyone. Murakeza Neza, benvenuti, and bienvenidos. Thank you for joining us.
Thank you. Thank you so much, Dr. Wolf, for providing me this opportunity and this kind introduction that you did for me. I am really honored and very excited to be here today from colleagues from all around the world. And more importantly, I would like to congratulate you for bringing up this very, very important topic of cardiobstetrics. And as you know, this is a topic very dear and near to my heart. With that, I would like to start by sharing my perspective. I'm a maternal fetal medicine, as you heard, and a cardiologist. So I kind of have been on both sides of the fence. So my perspective on cardiobstetrics. And why is this important? We know that maternal mortality ratio, which is the number of maternal deaths per 100,000 live births, it varies all around the world, anywhere from 1 to less than 20 per 100,000 in the US, to as high as 1,000 per 100,000 in some areas of the world. And if we clock them, every couple minutes, there's a mother who dies related to pregnancy. Looking at our own data in the United States, cardiovascular disease is the #1 cause of maternal mortality. And I'm not very proud to share this information, but over the last couple of decades, US is amongst the only one, actually odd one out, amongst the industrialized countries where the maternal mortality has been going up. And this literally is the only country outside of Afghanistan and Sudan where maternal mortality is on the rise. And along that, there's another very important area that deserves attention is the ethnicity. It's the African American Blacks that have 3 to 4 times maternal mortality compared to their white counterparts. And unless we address the gaps in maternity care, we are not going to be successful in improving mortality. With that, I would like to take you back to the maternal mortality reviews because there's a lot of lessons, important ones that we have learned that have helped us shape what we do now. We all know, all of us who take care of pregnant women, that if you didn't know this patient was pregnant, you'll have a woman sitting there who is complaining of reduced exercise tolerance, who is a bit short of breath, who may have palpitations, lightheadedness, dizziness, or syncope. And if you had this patient in your cardiology clinic, you'll be working that patient up for cardiac issue. But this is a normal pregnant woman. In addition, a lot of these women will have swelling, especially towards the end of the pregnancy. They have a JVD, they have murmurs. Almost all women who are pregnant in the later part of pregnancy have a soft murmur. So it's really important to dissect these symptoms and signs out when we talk about cardiac disease and diagnosis during pregnancy. And we know no matter what type of cardiac disease there is, the end result or the final common pathway how these patients present is either with heart failure, which is symptoms of shortness of breath, fatigue, not feeling well, to arrhythmias, which are palpitations, dizziness, and so on. When we reviewed the maternal mortality related to cardiovascular disease, most of these women actually had high blood pressure, they were tachycardic, they had physical examination findings, and their oxygen saturations were lower. So that actually separates these women out from an otherwise healthy, normal pregnant woman. A very important piece of information that I cannot overemphasize is the fact that when we review the maternal mortality, only 3% of 2 out of these 64 cases had a prior diagnosis of cardiovascular disease, which means that these are women with congenital heart disease or they actually carried a diagnosis before they got pregnant. Most of these women were either diagnosed during pregnancy and a large portion actually after delivery, which is the postpartum period. So looking at this slide, 3% before pregnancy and 48%, 34% plus 48 in the postpartum period. And unfortunately, these 48% were diagnosed at autopsy. So we had many opportunities along the way, but we were not able to diagnose them. And most of these women who are diagnosed in the postpartum period, they usually are cardiomyopathy patients, the peripartum cardiomyopathy that was overlooked, or and I would like to share a prototype case from our reviews a little bit later. When we look at the contributing factors, why did these women die? Why were we not able to make the diagnosis? And it's an eye-opening information where as much as we are guilty, 70%, patients and providers are equally responsible in ways that we can potentially correct in future. So these were women who were not, who didn't get the diagnosis in a timely manner. They were misdiagnosed. they were not referred appropriately, and the patients really didn't know that they may have cardiovascular disease, and they kept on waiting, not seeking medical care in an appropriate time frame. So this is an unfortunate case that has come up many, many times, not only in the reviews in the state of California, but all across the United States when there is a diagnosis of cardiomyopathy. Typically, it's a young woman, otherwise healthy. In this particular case, BMI of 38, African American, had a second pregnancy, uncomplicated vaginal delivery, who basically presents with fatigue and cough since delivery. She presents to the ED. Her blood pressure is 110/80, a little tachycardic, afebrile, with borderline low oxygen saturations. She gets diagnosed with respiratory infections, prescribed an antibiotic, goes home, comes back a week later, and now the antibiotics are switched, beta agonists are added, and 2 days later, the patient experiences cardiac arrest at home, and resuscitation attempts are unsuccessful, and autopsy findings are indicative of cardiomyopathy. I'll just take a moment there and stop and think, as there were many opportunities in this case, many couple times that this patient had presented, she could have been picked up as a cardiomyopathy. Based on this information, we came up with the CVD toolkit by the California Maternal Quality Care Collaborative. And this is one of the algorithms that is in there, which takes into account symptoms, vital signs, risk factors, and physical examination to determine if this patient has risk for cardiovascular disease. When we applied this algorithm to the mortality cases, 93% of these women would have been diagnosed as high risk for cardiovascular disease, requiring further cardiac care. So based on that, what can we do? What is our obligation now? I'll take you back. This is a slide from my very early days when I was a cardiology fellow, and we were in the we used to go to the OB clinic, and we had a lot of cardiology patients. And I know at that time, none of my cardiology fellows wanted to be in the OB clinic. And if there was a way, this is what it used to be, where an obstetrician did not want a cardiac patient in their practice, and likewise a cardiologist would not want a pregnant patient in their practice. However, and this was a big gap that we have been trying to bridge, and we have been doing it. I'm so glad that over time, and finally in the last few years, there have been more awareness, and we are trying to bridge this gap in a more systematic way. We are bringing the teams together, the obstetrics, the maternal fetal medicine, and the cardiology team, so we can provide better care. And I'm so proud of this document that was brought up, that was published by the American Heart Association this year, where they highlighted the importance of cardio-obstetrics team in the management of pregnant women. And basically, it starts with formulation of the team that starts off with preconception counseling, ideally, monitoring during pregnancy, delivery planning, and the postpartum period. And not only once the patient is delivered, who is high risk for cardiovascular disease, that's not the end of the story. These are women who not only need postpartum monitoring, but they also need appropriate contraception and counseling, and also the future risk for cardiovascular disease, as this is an opportunity in our healthcare system where we can make an improvement in these women's lives. With that, I would like to sum up by saying that cardiovascular disease, number one cause of maternal mortality, and up to 68% of these deaths are preventable. Cardio-obstetrics is the highlight. It basically is team building that is needed, especially in larger centers, and have a plan in smaller community centers in terms of referring and identifying these patients. And that would start with universal screening for cardiovascular disease in pregnancy. And of course, once you screen the patient, you would educate both patient and provider in the process. And that is what is much needed in this important area of maternal fetal medicine. Thank you very much.
Thank you, Dr. Hamid. Our Dr. Sue is going to introduce our next speaker. And now we are going to Toronto, Canada to hear the cardiology perspective. Dr. Sue, would you be so kind?
Certainly, I'm so glad to introduce Dr. Kansas Silverside, a professor in cardiology at the University of Toronto and their pregnancy and heart disease program. Candace is a leader and one of the founders of the field of cardiobstetrics in a very prominent program where congenital heart disease plays an important part in the care. Cardiologists play an important part of the care of congenital heart disease patients as they age. So we're so happy to hear cardiobstetrics around the world. Thank you, Candace.
Excellent. Thank you very much for that introduction. Thank you for inviting me to be part of this really fantastic session. I just want to confirm, can you see my slides clearly?
Beautiful.
Perfect. Okay, so I'm going to offer the cardiologist perspective, and I thought I would cover two main topics. First of all, I just wanted to talk about the history of cardiobstetrics and the role of various cardiologists over the years. And then I wanted to discuss some advances that have occurred in the field and specifically relating to risk assessment, organizations of care, and standard of care. So just to start out and to point out that cardiobstetrics isn't anything new. In fact, people started writing textbooks on the topic back in the late 1800s. It's obviously picked up over the last 20 to 30 years, I would say, but certainly it started a long time ago. And the original textbooks on cardiobstetrics really primarily related to rheumatic heart disease. And again, the topics have evolved with evolving patient populations. But here you can see some of the leaders in the field over the last 100 years. So as I mentioned, the field has evolved and it's primarily been related to the cardiac disease that's been found in women of childbearing age. And originally, most of the textbooks, if you open them up, really are about rheumatic heart disease. And here's an example of one of those early textbooks in a case they presented, which is a woman with rheumatic mitral stenosis. So she's a 35-year-old. She comes in at 7 months with edema of her legs. She becomes increasingly edematous. And of course, back in the day when cardiobstetrics started, there wasn't a lot of medical strategies to address disease. She began labor. She developed worsening heart failure, went into congestive heart failure, got worse, ultimately couldn't deliver and died in childbirth. So luckily we've come a long way since then in terms of medical and therapeutic options, but that's kind of how the field started. It was figuring out how to treat rheumatic heart disease. What's happened over the last 30 years or so is that women with congenital heart disease, specifically complex congenital heart disease, have now had surgical repairs in their pediatric age when they're children, and they've now survived to adulthood. And so what we're seeing is a new cohort of women with complex congenital heart disease who are now reaching childbearing age. So this is just an example of survival as it's changed in babies born with tetralogy of Fallot. And what you can see is in the early 1900s, there were very few survivors because there simply were not surgical options to correct this lesion. And over the time, survival into adulthood is increased. And if we had one more line on top, which I don't have now, but if we looked at all the babies born in the year 2000, so, young women, as they're reaching their 20s, if we looked at that cohort, we would find the line is even higher to just normal life expectancy at this time. And so what you can see is this field of congenital heart disease has been just blossoming. And in fact, many of you will know that congenital heart disease is now no longer a disease of the pediatric population. There are more adults with congenital heart disease than there are pediatric patients with congenital heart disease. And then what's been happening over the last 10 to 20 years is we've seen a new cohort come along. And this is a cohort of women with acquired heart disease and chronic acquired medical conditions. And that's occurred for a number of reasons. This just shows the change in maternal age in the US and different regions of the US simply over the last 10 years. And what you can see is even in that short period of time, there's been an increase in maternal age. And that results in more chronic conditions. For example, women with hypertension is increased, and in part this is due to advancing maternal age and other factors as well. But what you can see again similarly over a 10-year period is that there's more and more women starting pregnancy with hypertension. And as a consequence, there will be more chronic diseases, complications in pregnancy related to hypertensive disorders of pregnancy, preeclampsia, and perhaps more comorbidity in women with other pre-existing cardiac conditions. And finally, women, there's been increased prevalence of overweight and obesity in the general population, and certainly this has affected women of childbearing age. And as a consequence, more and more women begin pregnancy either obese, with obesity or overweight. And as a consequence, there's more complications related to obesity, such as obesity, cardiomyopathies, arrhythmias, and obviously fetal complications as well. If you look at any of these cohorts of women, on the x-axis is different ethnicities, and you look at the rates of obesity and overweight, you can see in any different ethnic group in the US, at least 50% of the women beginning a pregnancy are obese or overweight. So what are the actual rates of complications in women with pre-existing heart disease? Well, there's been a number of large cohort studies. This was just a summary that Matthias Grootman made a number of years ago, looking at the complications rates in 3 large studies: the CARPREG study from Canada, the Sahara study from the Netherlands, looking at women specifically with congenital heart disease, and the ROPAC study, which was a multinational study looking at women with acquired and congenital heart disease. What you can see is women who have pre-existing heart disease have rates of complications in pregnancy anywhere between, say, 8 and 16%. Most of it relates to the dark blue bars, which are heart failure, or the light blue bars, which are arrhythmias. And luckily, very few very few complications really result in maternal mortality, but they do occur, as you've just heard a lot of details about that. Similar to the data you just saw on maternal mortality, we looked at women who had really serious life-threatening conditions in pregnancy. So, heart failure where you end up in an ICU intubated, ventricular tachycardia where you end up in an ICU during your pregnancy, as an example. And we looked to see how many women that had really serious complications, not just those who died, but those who had serious complications. We wanted to find out how often it occurs and how often it was preventable. And what you can see here is when we look at all those women, we had about 2,000 women with pre-existing heart disease. 3.6% of them had a really serious life-threatening condition in pregnancy. And when we looked at whether or not they were preventable, we found that half the admissions were preventable, and primarily they were related to primary provider management issues, as I've shown here. So somewhat similar to the maternal mortality you were just shown. So I think there is a lot of things that still can be done. One other thing that's happened kind of in this field, obstetric cardiology, is that we've started to look not just at what happens in pregnancy, but kind of a lifetime risk. So not only do we think about what is the risk of your pre-existing heart condition, not only in pregnancy, but outside of pregnancy and its natural history, but the impact of added acquired risk factors, and then the further impact of complications that occur in pregnancy and their association with worse maternal cardiovascular outcomes over the long run. So I think what we're starting to do is really take a much more holistic view of risk in this population. So how do we look at pregnancy risks and how do we predict them? Well, there's a lot of different ways you can do this. You can just ask the experts. You can become an expert. You can actually look at derived risk scores, which I'm going to talk about in a few moments. These were mathematically derived risk scores that try and identify the main determinants of adverse outcomes during pregnancy. You could look up what's known about any given lesion. So you could look up, say, aortic stenosis and find all the literature on aortic stenosis. And I'm going to tell you why I think you need to comprehensively use all these tools to come up with a global risk. And then finally, even after you use these tools, I think it's also important just to be a good doctor. Think about other things that are specific to that population, whether or not it's their MRI data, whether or not it's genetics or other comorbidities, and really integrate everything to come up with a risk. And so I'm going to walk you through some of these tools that we use for risk assessment. The first tool I mentioned is just expert opinion. And the most widely known expert opinion tool is the WHO classification. This was originally developed by a British working group, and now it's been incorporated into the pregnancy and heart disease guidelines, and is really used worldwide. This looks at different specific cardiac lesions and classifies them into 4 categories, with 1 being the lowest risk category and 4 being the very highest risk category. And so just to remind you, this is from the older ESC guidelines, showing you those rare conditions when pregnancy is associated with significant maternal mortality and pregnancy is in fact contraindicated. And so I think in some ways, these are the most straightforward because we know no matter what, they're associated with high risk. But I do think risk assessment gets more complex when you're not in that slam dunk category. So for instance, if you look at moderate mitral stenosis, it's a class 3 based on the WHO class. So class 3 is significantly increased risk of maternal mortality or severe morbidity by definition. But take a look at the right-hand side of your screen and look at the different kinds of women that might have moderate mitral stenosis. You may have a woman who's asymptomatic with moderate MS. You also may have a woman with moderate MS who's symptomatic with, say, class 3 symptoms. A woman may have moderate MS and have had recurrent atrial arrhythmias and a stroke. Or a woman also may have moderate MS and have an RVSP of 70. And I want to point out that I don't think any of us think all these women represent a unified risk. So I do think just simply classifying things based on one lesion is perhaps too simplistic. And so are there other tools we can use to better assess risk? And one tool that I think is really useful that has been widely used is the CarPreg risk score. So this is a risk score that was prospectively derived. It's based on the main predictors of adverse outcomes in women with pre-existing heart disease. And what you can see here is that there's 4 main predictors that were identified. You get a point for each predictor, and the more predictors you have, the more likely you are to run into adverse outcomes in pregnancy. And you can calculate the points and then subsequently calculate the maternal risk of cardiac complications during pregnancy. Back to my point about kind of working with the lesion and then stratifying according to some of those CarPreg risk factors or those variables that are a little bit more physiologic in the CarPreg score, like low EF, outflow tract obstruction, or a history of heart failure. If you look at the WHO class on the x-axis, and then you stratify each of the different WHO classes according to CarPreg score. So if, say, you have a woman with moderate MS, and then you further integrate those CarPreg variables, whether or not they have a bad EF, pulmonary hypertension, a prior history of adverse events, you can further stratify any of those WHO classes and get a better sense of risk. We've subsequently gone on to develop the CarPreg 2 risk score. This is a risk score that integrates, again, those older CarPreg 2 physiologic variables, some of the high-risk lesion-specific variables. And then a really important one is the one you can see here in red, is that also independent of all the other maternal risk factors, late pregnancy care. So delivery of care is important. And this is the first time we've been able to show, independent of what you have, how you get care is important. And just to wrap up my comments on risks, I think, it continues to evolve. There has been also risk scores specific to different populations, like the ACHD population, the rheumatic population. Some risk scores are better for specific regional areas. And then finally, new risk scores will ultimately be developed that will integrate other things like genetics or cardiopulmonary testing, or perhaps, novel biomarkers. So I think there's still more to come. I think we can ultimately and always do better, but I think we've come a long way over the last 20 years. And I'd just like to add a few more comments about organization of care and standards of care. You can see to look after a woman with heart disease really requires a lot of coordinated efforts, not only in terms of coordinating cardiac care and surveillance and testing, but also obstetric testing, surveillance. Perhaps you need genetics, you need nurses, you may need social work. You have to plan how you're going to deliver these women. And it really is important to have that team. You've already heard of it, but I'm just highlighting it one more time. There's lots of literature coming out about how to coordinate these cardio-obstetric teams, or there's heart teams, and they have many players, although often led by cardiologists, MFMs, and OB anesthetists. And there's my team. I mean, this is only some of my team. It's much larger, but I'm very fortunate to work really collaboratively with my team. The other thing I'd like to say about the cardiac clinics is it is really important not only to have a team, but figure out how a team can work together. So in Toronto, this is my hospital on the left-hand side of the screen, but inside the hospital on the right, and we have two side-by-side hallways. One is for the OB team, one is for the cardiology team. In between is a room, two patient rooms. We ripped down the wall, and you can see a picture here of Jack Coleman and the cardio-obstetric team. And there's a table for OB and a table for cardiology. And when we have complex cases, we're physically in the same spot at the same time, and we can improve communication. We also have combined rounds. This is probably about half the room. It shows about half the room, but these combined rounds are to discuss complex cases. And in there is not only trainees and physicians, OBs, cardiologists, MFMs, geneticists, social work, nurses, but it really is everybody involved in patient care. And when we have really complex cases, we discuss these, and we do this weekly. And then finally, I think it's really important to disseminate this information widely to the whole care team so everybody has a plan. And this is just an example from the New York team that's published about their team planning form. And I think it's an excellent article and an excellent example of how to do it. So finally, my last comment about these teams is, do they make any difference? Well, in Toronto in the year 2000, we formally established a team at one center, like I've shown you. And so we looked at our cardiac outcomes before and after that time. Before is the light blue, and after that time is cardiac outcomes once we had that formal clinic. And overall, we didn't have a huge drop in adverse outcomes. But when we looked at individual outcomes, so I've shown you here pulmonary hypertension on the right-hand side of your pulmonary edema, on the right-hand side of your screen. What you can see is we were able to half the number of events, of heart failure events, once we established that clinic. So I think there's hope that you can do things better by establishing these clinics. And my last thoughts in terms of where we're at and where we're going is the improvement we've made in standardizing care. And so probably everybody here has heard of the ESC guidelines on cardiac disease and pregnancy. They were originally published in 2010 and then subsequently revised in 2018. This is a fantastic document with input from all around the world, and it's really granular details about how to manage women. I just wanted to highlight a few take-home messages from this standard document for recommendations for delivering care as it relates to what I've talked about so far. First, there's a class 1 recommendation that all women with known or suspected cardiovascular disease should receive preconception counseling. In addition, those at high risk, but it actually, I would say intermediate or high risk, should be seen by a pregnancy heart team and cared for throughout the duration of their pregnancy. This is a new statement from the AHA looking at the care of pregnant women as it relates to cardiac considerations. And this is a first statement that really highlights the fact that we should be training the next generation to start appreciating this field and have some knowledge base in this field and understand when to refer and how to care for these women optimally. Besides those documents, there's other very specific documents. This is a document on the care of patients with congenital heart disease. There's similar statements out from the ESC on how to care for women with cardiomyopathies, or embedded in other AHA documents, or how to care for pregnant women. This is just an example of how to care for the pregnant women at the time of cardiac arrest. And I'm going to leave you with this very last slide because I think it highlights something important. Never when I started did I think there would be a presidential advisory jointly from the AHA and ACOG talking about managing women during pregnancy. This really relates to that concept of adverse pregnancy outcomes ultimately predict long-term maternal cardiac health. But the statement made in this presidential advisory is that OBGYN and cardiology providers can improve cardiovascular health, enhanced collaborations. And I'll leave you with that comment. And thank you once again for inviting me to be part of this absolutely fantastic session. Thank you.
That was terrific. Thank you, Dr. Silversides. My name is Dr. Anna Bortnick. I'm from Montefiore Medical Center, where I am an interventional cardiologist and assistant professor of cardiology. And I have the pleasure of moderating the discussion about the two presentations that we heard from Dr. Hamid and Dr. Silversides. And I specifically want to invite my colleague, Dr. Ellen Harrison, who's an associate professor of internal medicine and also an assistant professor in the Department of Obstetrics and Gynecology and Women's Health here at Montefiore. She has a very vast and deep knowledge of what it is like to take care of women with cardiac conditions in pregnancy. And I wanted to ask you, Dr. Harrison, could you reflect on how that care has evolved over the past decades and your thoughts on how the collaboration should work and should thrive?
Well, thank you. I'm very honored to be included with this august group of speakers about our experience right here. I mean, I would say, speaking to Diana about this, the notion about specialization and the ability to break down the walls between specialties and put these different kinds of physicians together to care for these patients was one of the themes that I think wanted to be discussed. What I'd say is we're in this tide of increasing specialization, fragmentation of care, people knowing more and more about a deeper and deeper knowledge of smaller fields. And yet there's, of course, a dialectic, which is at the same time, there's a simultaneous drive to close the gaps between these specialties because patients do not neatly fall into our little categories. My experience here, I've been taking care of medically ill pregnant women for 42 years. My background is not as a cardiologist, but I've been an internist and for many years a critical care director. So taking care of many cardiac patients in that setting. My initial involvement of this began with a case that I think is pretty emblematic of what it was like at the beginning. So this was a patient who was hospitalized. She was in the ICU. It was in the middle of a terrible crisis. And the way that the team was brought together to care for this patient was on a completely ad hoc basis. People who didn't work together normally, none of whom had taken care of this patient before, brought together for this single event without really anything that came out of it that continued to inform us about these patients and the kind of care that they needed. That's what most of these early collaborations were like. And sometimes it worked, it didn't always work. I think, as was alluded to before, there's a lot of reluctance on the part of people on both sides of this to get involved with these very sick patients. Some of it comes from a lack of knowledge, a fear of doing something. They don't know what their treatment is going to do to the fetus. Just a lot of concerns about getting involved in these patients and a variable degree of intense reluctance to take care of these patients. In these kinds of ad hoc or consultations that were set up for patients, there's no lasting relationships, there's no ongoing teaching, and that is something which I think has changed dramatically. So since that time, first of all, MFM has become a much bigger presence in the field, and there were many more very well-trained obstetricians with an interest in taking care of sick patients. So some of that reluctance, I think, disappeared as MFM became more and more of a presence. And the way that, rather than these just ad hoc consultations, the way collaboration moved in the next step was to cultivate relationships with specific physicians in certain subspecialties, in this case, of course, cardiology, finding someone who you trusted, respected, who was at least interested, if not enthusiastic, about taking care of these medical patients. Here in this institution, we worked with primarily 2 cardiologists, both generalists, who were able to weigh in on all the various aspects, and also tend to be older, so they had trained before everything was so fragmented. And Dr. Martin Cohn, who I think is on this call today, and Robert Foreman were the doctors who doctors went to, the doctor's doctor, the people the professors went to, and that the chairman went to for their cardiac care. They were the people who we used. And that was helpful, but it didn't go beyond what we need to do, which was alluded to also, is that we have to be able to teach people in the next generation to be able to step in and take care of these patients, and to build that in. And so from the beginning, right after those collaborations were set up, we began doing conferences for, among the things we did would be conferences for the cardiology fellows, a case conference that Dr. Cohn and I did for the cardiology fellows for a few years. There's boot camp for all the subspecialists, including cardiology and critical care, when people start their fellowships in July, getting into that curriculum, sending the MFM fellows to the ICU so that they're more comfortable with some of the critical interventions. That was now, I believe, mandated by their training institution, so it's not just a local decision. There were simulation exercises in how to do CPR that were done for both OB and for critical care medicine. Internal medicine rotations for every primary care trainee in our program to do a month or a rotation in women's health, which included high-risk clinic, and some at least exposure to these concepts to try to make this be a more comfortable area for people who are not obstetricians to get into. We were very involved in preconception initiatives, both locally with a dedicated grant-funded clinic that completely dissolved when the money disappeared, and also worked with the March of Dimes to get that into the curriculum of every single primary care specialty in the country. So both ABIM, but also the pediatric family practice, OBGYN training leaders, getting those questions on the boards and making that something that was happening, not just in our own institution, but more broadly in the country. So thank you for allowing me to speak. I so much enjoyed the earlier presentations and learned so much from them. Thanks a lot.
Fantastic overview. Thank you, Dr. Harrison. My second question has to do with an observation of the 2 talks. I wanted to ask this question, maybe I'll ask it and direct it to Dr. Hamid and Dr. Silversides also to comment. I noticed in Dr. Silverside's presentation that the proportion of Hispanic and Latino individuals, women with obesity and overweight, is fairly high. But I noticed in Dr. Hamid's talk that there was less mortality in the Hispanic Latino group. And I'm wondering if there is some sort of paradox there. Can we maybe discuss that for a moment? Is there something known about that particular cohort?
I think when we look at the mortality data in California, obesity definitely is one of the risk factors. And that is why we factored in obesity when we formulated the algorithm that I briefly shared with you. So obesity by itself is a freestanding risk factor, whether it's in any ethnicity. Now, when we come to African Americans, there is something there And perhaps it is a combination of risk factors that have not necessarily been diagnosed yet. Higher prevalence of hypertension, higher prevalence of microvascular disease, and such that puts them at a higher risk. So an African American with obesity is going to be at a much higher risk compared to, say, any other ethnicity with obesity alone. And this is across the board, all through the U.S. The prevalence of cardiovascular disease, prevalence of morbidity and mortality in African Americans is many-fold higher than others.
Yeah, I would agree. I guess the only thing I would add in is I think we're just starting to understand ethnicity and how it impacts outcomes. I mean, I think we're at the very start, and I think in 10 years from now, we'll have some better answers. But I think that what we know is pretty crude at the present time. We mostly know that outcomes differ, but really teasing out the mechanisms, I think we're far away from that point at this stage.
Right. And I'll just add one thing. In California, we have a large Hispanic population. When we look at our 500,000 deliveries every year, the majority of the major ethnic group is Hispanic. However, when we look at their mortality, they don't make up as much percentage-wise as African Americans, even though they're less than 5% of the population here.
With that, I would like to keep us on time and turn the microphone back to Dr. Wolf, who can introduce our next case, or our first case, rather.
Actually, I'm going to take over. I'm Daphne Sue. I'm the Director of Pediatric Cardiology and the Director of the Cardiology. First two talks, fantastic. And we're now going to move to presentation of 3 cases, as Diana said, from around the world. This is a case from Rwanda of mitral stenosis in pregnancy. It is going to be presented by Polyfield Nihinura. I believe I probably butchered that, but he is a lecturer and assistant professor at the University of Texas College. We really thank him for joining us. I'm very interested in hear what he has to tell us. Dr. Polyfield.
Go ahead and unmute yourself.
So the first case you present, this is Dr. Polyfield Nihinura. I'm presenting a case that we followed in our department from the University Teaching Hospital of Kigali. It's a case that has different conditions, one condition that happened 2 times in different years. So we are starting with her story in 2019. This is a 24 years old who presented her first pregnancy at 17 weeks, 5 days by date. She consulted with shortness of breath, orthopnea, paroxysmal nocturnal dyspnea for 2 days, and this was associated with hemoptysis. And she had been managed as an OPD patient at a secondary level hospital with no improvement, and she was then transferred to our referral hospital. Her past medical history was consistent with one antenatal care that did not assess her cardiac system, and it's also positive for dental caries. Her general status at her admission, she was altered with severe respiratory distress. She was tachycardic, and she had oxygen saturation at 60% on room air, and she had respiratory rate of 56 cycles per minute, with marked use of accessory respiratory muscles and decrease in air entry in both lung fields, with bilateral crackles, which was prominent in the left lung base. Her heart sound were audible with apical systolic murmur, graded 3/6, and she had a gravid uterus with no hepatosplenomegaly. At admission, she was viewed as a patient with pulmonary edema secondary to possibly heart failure and or valvular heart disease. Pulmonary embolism was also included given that she was at risk. And we also thought of severe pneumonia, of course, on an evolutive pregnancy. She was given IV Lasix, atenolol, enoxaparin, and antibiotics, and supportive management with oxygen 15 liters per minute, and we elevated the head side of the bed. We involved anesthesiologists to review her and possible support with a respiratory machine. Unfortunately, they contacted everywhere in the surrounding hospitals. There was no bed in ICU, and therefore she was just admitted in HDU with no mechanical ventilation. Her labs were otherwise normal. Her imaging, her obstetric ultrasound revealed a normal growing fetus with no gross abnormality and no ascites. On the next day of admission, she underwent a heart ultrasound that revealed severe mitral stenosis with mitral area that was 0.9 centimeter with mid-mitral regurgitation, and ejection fraction was fair, was 56%. She had calcification on both mitral leaflets and dilated left atrium with small left ventricle. And the cardiologist recommended to maintain the beta blockers and add penicillin, and recommend that this patient may need valve replacement therapy as the definitive management. The CT angiography was normal, and therefore we stopped her enoxaparin. And in hospitalization, her oxygen saturation at this time was 82 to 90%, was pretty good on Lasix. And we discussed with her about termination of pregnancy, which she denied. She was newly married, actually, and we had to involve the psychologist to convince her. On her day 5 of admission, she opted that she may think about pregnancy termination, but she requested for 1 week to think about that. So as patient autonomy was prioritized and her involvement in care was respected, we accepted that. And 5 days after she accepted pregnancy termination, she developed another acute episode of respiratory distress and hemoptysis again. She involved her husband, and with our psychologist, they accepted pregnancy termination, and she aborted. She had complete evacuation at 19 weeks, 4 days, and she improved on oral Lasix. And after cardiologist review, the cardiologist reviewed her again on day 11 post-abortion, and she had improved, and she was no longer dependent on oxygen. And then at this time, she was discharged on warfarin and atenolol, and she chose the pomedroxyprogesterone acetate as family planning. But then after 2 years, as she wanted to save her marriage, she was regarded in her family as the source of not having a baby. She skipped just 1 dose and she got pregnant, and she consulted a different doctor to whom she did not reveal that she was a cardiac patient, and she did not have any problem in her first trimester, and they at least dated her. So at 24 weeks, she presented here again with hemoptysis and acute onset of shortness of breath, and she had stopped actually her Lasix again. And at this time, her vitals were normal, and her lungs were clear, no crackles actually, but she had a murmur that was graded 5/6. Her cardiac ultrasound revealed severe mitral stenosis, dilated left atrium without thrombus. We kept IV Lasix, we gave dexamethasone for the baby, and actually the patient was discharged after 4 days with good improvement and on oral Lasix. And in this October, she presented again complaining of abdominal pain with increased urinary frequency and fainting at home. This was alarming, and then we involved, her physical exam did not reveal any sign of labor, but her urinalysis revealed yes, for which she was given antifungal drug. Her obstetric ultrasound was normal fetus, with biophysical profile of 10. Her heart ultrasound was moderate mitral stenosis with mitral valve of 1.3 centimeters and ejection fraction 63%. However, later on in her antenatal consultations, she was found her fetus had turned breech, actually, so which subjected her to a cesarean delivery on November 30th, that is 17 days ago. She underwent cesarean delivery under spinal anesthesia with intrathecal morphine and with a healthy baby of 2.6 kilogram. And during her surgery, you can see here, her oxygen saturation was maintained at more than 98% on oxygen. Her BP was maintained, her systolic BP was maintained between 90 to 130, and diastolic maintained between 40 to 70, and her heart rates never went above 120. So her postpartum was uncomplicated, actually. She did not require oxygen, and her heart ultrasound on day 3 postpartum revealed moderate mitral stenosis, mid-calcification. Mitral area was now 1.6 centimeter, and she was discharged on Lasix, atenolol, aspirin, and penicillin, and she's now on follow-up by her cardiologist. And she opted for IUD that she will come for in January 2021. So in summary, this is a 26-year-old with pregnancy complicated by severe mitral stenosis and with mid mitral regurgitation with previous history of pregnancy termination for maternal life-saving, for whom a holistic teamwork of obstetrician, anesthesiologist, cardiologist, and psychologist maintained the pregnancy to term and underwent an uneventful cesarean delivery. So as a key message, mitral valve dysfunction in pregnancy is a challenge in low resource settings where this patient required an ICU bed, but she couldn't find it. She required immediate cardiologist review, but she had to be scheduled on a day. She met cardiologists like 1-2 days, sometimes 4 days after she was admitted. And teamwork with involvement of critical care and psychologists also can actually improve the patient outcome. We emphasize on adequate documentation that helped us follow this patient based on her previous events that was well documented, and health education to high-risk women should be emphasized and inclusive of contraception. Thank you very much.
Thank you so much, Polifield. That was a fantastic case, and congratulations on the management. We're able to get that lady to term and have a healthy baby. It's really a testament to your teamwork. I wonder, what will you, how do you approach women or girls as you discuss pregnancy, as you discuss issues that may come up if they have rheumatic heart disease? Is before they become pregnant, to try to get people to understand, women to understand that they need to have care throughout their pregnancy?
Sorry, it cut off. I missed some words. Sorry.
To your girls who have rheumatic pregnant.
I can't hear you well. Maybe somebody else.
Yeah, no, what Dr. Sue is asking, and Dr. Sue, correct me if I'm wrong, is about the preconception counseling for these patients in Rwanda. Is there a discussion? How do you and the team in Kigali and other parts of Rwanda deal with that aspect of these patients who have known rheumatic or other heart disease? Is that right, Dr. Sue?
Exactly, yes.
Thank you very much. So first, in Rwanda, we encounter cases of cardiac diseases and pregnancy, and what we tell them, what we share with them, is that this is not a contraindication, an absolute contraindication to pregnancy, but we need a proper follow-up or view. And in case we meet her before she gets pregnant, unfortunately, we meet most of them when they come already with symptoms of cardiac dysfunction already on pregnancy. So we don't always have preconceptional counseling to them. Maybe we counsel them when they come to with the current pregnancy. That's when we have a chance to meet them and talk to them about the pregnancy, the future pregnancies. I don't know if I'm going to call that a preconceptional counseling, but actually that's the only we have. Otherwise, we discuss with them about the pregnancy that they are carrying at the moment, and we give them a message that we need them for preconceptional care, but unfortunately, we don't get them for preconceptional care. We only meet them when they're already pregnant and they have cardiac disease. For example, as we discussed here in previous discussion, that they could be benefit from calcium. We don't meet them. We don't have a chance to meet them and give them that calcium preconceptionally.
And how do you assess or present to you? How do you decide them to terminate? Is it solely on the severity of disease, or can you do it prior to that based on?
Was the question on how do we decide on pregnancy termination? If we decide that based on the clinical presentation, or we can decide that given the diagnosis that we already know? Okay.
Are there imaging criteria to predict severity?
Thank you very much. We are limited on that. The imaging criteria that we have is that we do a cardiac ultrasound, and for patients who are already known to have cardiac diseases before they get pregnant, usually the thing is patients sometimes they are on one side that they think we stop them, we advise them not to get pregnant for maybe our benefit. Sometimes they think we are just against them, and it's a challenge that they go and get pregnant without, talking to doctors, thinking that we lied to them actually because they are feeling healthy. When they are not pregnant, they're feeling healthy, they're getting medicine, and they think that if they just continue getting medicine, they will be healthy throughout the pregnancy as well. And they don't come to us. They think we are only going to tell them not to get pregnant if they, do as much as they can not to get pregnant. But actually, those who to whom get to us at least in the first trimester, sent to us by their cardiologists to send them so that we can discuss with them when they're pregnant in first trimester. We discuss with cardiologists actually, and we mostly decide on pregnancy termination when they have the symptoms. I remember one case that I personally met who had a pregnancy in cardiac disease, and for this particular patient, she had been told by her cardiologist that pregnancy is a risk to her. And when we counseled to her about pregnancy termination, she was fully aware that this pregnancy can be a risk to her. And she was aware that whenever she starts developing the symptoms, that she should come at the hospital. So when she started developing paroxysmal nocturnal dyspnea requiring pillows, she came to the hospital, and unfortunately, she eventually had severe respiratory distress that required her to go to ICU, and we terminated her pregnancy. But at least she was pregnant, she kept her pregnancy, and she was aware at any time it can be terminated when she gets worse.
Well, it was a fascinating case. Thank you so much, Dr. Portfield. I believe we're on time to go on to our next case. And that introduced by Dr. Bortnick.
Yes, thank you. We're going to move on to Milano, Italy. We have Dr. Sala with us today. She is from the Università degli Studi di Milano, Ospedale dei Bambini Vittore Buzzi. She's going to speak to us and we'll discuss another complex valvular case.
Hey, hello. Thank you for a presentation. We are talking today about heart failure in IVF pregnancy. So the clinical case I'm going to present is about a 47-year-old woman, an Italian woman in her first pregnancy. The pregnancy occurred by in vitro fertilization with the patient's frozen egg and intracytoplasmic sperm injection. The patient has always enjoyed good general health. She was diagnosed with multiple sclerosis in 2006, but the disease is in the non-active form. Regarding her family history, her father had an acute myocardial infarction. On the mother's side, instead, there is no family history of cardiovascular disease. Regarding her pregnancy, the course was regular. US controls were normal, including uteroplacental and fetal Doppler velocimetry. Actually, the patient was told to measure regularly her blood pressure in the second part of the pregnancy because of her risk factors. So IVF pregnancy, familiarity for heart disease, and her age. She went at 35 weeks of pregnancy to the hospital. She went to the ER because of borderline blood pressure values at home. After she was given the therapy with nifedipine 20, blood pressure progressively normalized. Her blood exams were good, including SFLT1 PLGF ratio that was negative. US control were good, fetal heart rate monitoring was normal, and she has always been asymptomatic for scotoma, headache, and abdominal pain. So she was discharged after 3 days with blood normal pressure values with nifedipine. Delivery was indicated at 38 weeks of pregnancy because of gestational hypertension. So she had the cesarean section upon maternal request. The surgery went well. The baby weighed almost 3 kilos and the umbilical cord gas analysis was actually normal. 5 days after surgery, she went to the emergency room because of dyspnea. Her blood pressure was really high, as you can see here. Her body temperature was actually good. The oxygen saturation was low, and on objective examination, she had bilateral pitting-led edema and diminished vesicular breath sound. The nasopharyngeal swab for COVID was negative, but the patient underwent an urgent chest CT scan with and without contrast. And here you can see the images of the CT scan. So you can see bilateral pleural effusion greater on the right. So it was 4.5 centimeters on the right part versus 2.5 on the left side. The radiologist reported also thickening of the interlobal septa and ground glass areas, so greater on the right as well. Left atrial and left ventricle dilation and ectasia of the pulmonary arteries were also present with no signs of pulmonary thromboembolism, as you can see here. So in summary, the patient, given the sign and symptoms, the radiology recommended an urgent cardiological examination in the suspicion of cardiogenic pulmonary edema. So an urgent electrocardiogram was performed, showing no signs of left atrial enlargement or left ventricular overload. Sinus rhythm was present and the heart rate was normal, so 63 BPM. On auscultation, it was appreciated and holosystolic are murmur grade 1-2, diminished vesicular sound, and bibasilar crackles. So on the suspicion of a pulmonary edema and valvular insufficiency, the cardiologist performed a transthoracic echocardiogram. As you can see here, the left ventricular size was normal. The ventricular myocardial thickness was normal, but the left atrium was enlarged, so the volume was 83 milliliters, considering normal values about 1530. These images show the presence of mitral insufficiency, defined as severe by cardiologists, and hyperechogenic, thickened, and stiff mitral flaps. There was no sign of valve prolapse. Systolic function was preserved, so EF was 55%. Estimated mean pulmonary artery pressure was high, 42, considering normal values ranging from 12 to 16. And all these findings could explain the pulmonary response to the cardiological pattern and the patient's symptoms as shortness of breath. So in summary, the patient was having an acute heart failure, probably due to hypertension and severe mitral insufficiency. She was given a loop diuretic, furosemide, and ACE inhibitor, and oxygen therapy. And she has been recommended fluid restriction to avoid worsening of the heart failure. Since the admission at the hospital, her vitals have been strictly monitored according to modified early obstetric warning score. So vital parameters are written in the correct line, and depending on their value to which a particular color is associated, shall be rechecked according to precise timetable. And here you can see the vital. In the first day, when the patient was admitted to the hospital, she had an increased respiratory rate and low oxygen saturation compatible with dyspnea. She was having a normal body temperature and normal heart rate. And according to WHO classification on blood pressure levels, she was having a grade 2 hypotension. Here, you can notice an improvement in saturation and respiratory rate with oxygen therapy, and the patient no longer had shortness of breath. Before adding nifedipine 20 to the therapy, systolic blood pressure has always been greater than 160. But day by day, her vitals got better. After stopping oxygen therapy, saturation and respiratory rate maintained normal. She no longer had dyspnea. Only blood pressure continued to remain above normal range despite therapy. And these are the patient's blood tests that they were actually normal, except for a mild anemia compatible with the postpartum state and hypokalemia, probably due to the loop diuretic. So on the advice of the cardiology, potassium chloride was added 3 times a day at the therapy. On the third day, she was at the hospital. A new cardiovascular examination was performed, showing a clear improvement in cardiac function. So vesicular breath sound was heard through the lung, and bibasilar crackles were absent, and the patient had no more leg edema. And even her vitals shows a clear improvement in the clinical condition of the patient. So almost all the values were within normal range. This is the new transthoracic echocardiogram. So as you can see here, the atrial size was actually now better, 41 milliliters. She had a mitral insufficiency that became mild to moderate, but the mitral flap was still thickened. You can see here a third order chordae tendineal rupture. The pleural effusion became mild, and the pulmonary artery pressure was actually now normal. These are her blood tests, which have been done every day, and which show a clear improvement in her hypokalemia that actually resolved. So she was discharged after 5 days. She was asymptomatic now, in good cardiocirculatory compensation. She had no more pleural effusion, and her blood pressure was actually normal. So in the end, what is the diagnostic hypothesis? So probably the patient has actually a misrecognized primitive mild mitral insufficiency that never caused any symptoms. So she has never undergone any cardiological checkup before because she's always been good. And as there were no ultrasonographic signs of valve prolapse, it was hypothesized that the primary valve damage was actually rheumatic in origin because of the valve leaflets that appear thickened and stiff. The state of hypervolemia typical of pregnancy and the progressive return to a condition of normalcy in the postpartum together with hypertension and an excess of fluid intake during pregnancy, because the patient actually reported drinking 3-4 liters of water a day, have determined the acute heart failure. In particular, the echocardiogram images suggest an acute to chronic heart failure, especially given the left atrial enlargement. The patient is now in a regular follow-up, in a regular cardiological follow-up. She no longer takes any therapy, but a mild metralic insufficiency remains. Thank you for listening.
For this presentation of this very interesting case with acute heart failure 5 days postpartum, which is one of the vulnerable periods that Dr. Hamid had mentioned when we see increased mortality. Could you describe, if we go back and we see this woman when she first comes to the in vitro fertilization clinic, the reproductive endocrinologist, how can we catch someone with a possible cardiovascular issue up front before we find out these complicating factors? What should be the screening for pre-existing cardiovascular disease in the IVF setting? And this is open to debate. There's no absolute guidelines here. So I would like to hear different opinions.
Okay. So we think that IVF is actually not a risk factor for cardiovascular disease itself. The problem is that usually IVF pregnancy occur in women of advanced age, and age is an important cardiovascular risk factor that shouldn't be underestimated. So in advanced maternal age pregnancy, the cardiovascular adaptation typical of pregnancy, such as increase of cardiac output, hypervolemia, are more difficult to tolerate. And this can result in outbreaks, cardiovascular problems, or in new cardiovascular problems, as actually occurred in our clinical case. So we believe actually that cardiological investigation is actually necessary in all those women with advanced age, familiarity for cardiac heart disease as the patient that I told about, and that develop any type of hypertensive disorder in pregnancy, from mild one to severe one.
Great answer. I think, Dr. Hamid, you have a question about this case.
Yeah, first of all, it was a wonderful presentation. Thank you. Thank you, Dr. Sala. I was curious, you had mentioned the SFELT1 and the PLGF in the diagnosis of preeclampsia. Is that the standard that you use in addition to the usual criteria that we have?
Yes, we actually use these in addition to other criteria. So like a prediction of preeclampsia. So we used to do it in all the women that have any sign or symptoms, for example, hypertension or proteinuria or intrauterine growth restriction.
What is the normal?
Sorry?
What is the normal value that you look for?
Under 84.
84, I see, okay. And the other thing, I was really pleased that you actually use the maternal early warning criteria, the scoring system. Is that the standard through your system, or is it just at the university?
No, we use this in hospital every day. All the vitals of the patients are taken using Muse.
That's wonderful. What I did not see is the BNP level. Do you consider doing B-type natriuretic peptide levels in patients who come in with shortness of breath, especially pregnant or postpartum?
Actually, we didn't the BNP this time, but we should have done. So I think we can start now. It's important.
Great, good job.
Professoressa Chetin has raised her hand. She would like to say something.
Thank you, Diana. Well, first of all, I'd like to say that Valentina is in her first year of residency, And I must really say that, Valentina, you really did a great job, really. Very, very good presentation. I agree. I'm very proud of you. Anyway, I wanted to say to Dr. Hamid that I work in, I'm very much involved in maternal mortality surveillance in Italy. And so I was very happy to listen to your presentation. And anyway, so a couple of years ago in Italy, we had a cluster of maternal deaths, particularly of sepsis, maternal sepsis, but not only maternal sepsis. Also, I don't know why, it was very unfortunate here. And when we did when we evaluated the cases, we realized that using the MAOs, the maternal early obstetric warning signs, was actually the most important thing that should have been done correctly, because most of these women actually had vitals that showed, that should have warned the health professionals to do something more. And instead, nobody really was putting enough care into that. And therefore, when we introduced this scoring system, there was really an incredible improvement. I mean, this is now, in my region, this is now done in every maternity unit for every pregnant woman that is hospitalized. She has to have a certain times a day these warning signs taken regularly, and depending on the reason of her hospitalization, the frequency has to become more or less. But it's very, very useful, because midwives, nurses, doctors have, a simple way to say, one red, two red, one yellow, what should I do? And they call the anesthesiologist, they call the cardiologist. I mean, we need to have this, it's very important, I think. Thank you anyway. Thank you very much.
There's a couple questions from the chat that I just wanted to mention. A midwife from New Jersey, Camila, was asking about the recommended follow-up with a cardiologist post-delivery for patients with gestational hypertension. In the case that Dr. Sala just presented, interestingly, that's how she initially, that was her, besides her IVF and her age, she did have the diagnosis of gestational hypertension. Would we follow her up? Let's just say this didn't happen. Should she have been seen 1 week, 2 week, 4 week, 12 week postpartum? What myself and Dr. Hamid were discussing in the chat is we would probably recommend 12 weeks in general, but perhaps a patient who has other comorbidities and other risk factors maybe sooner. But wanted to ask if any of the other panelists had any other thoughts about that to answer our midwife from New Jersey. Thank you for your question.
Yeah, I just wanted to clarify. I think there are two components. One is the immediate follow-up. As we all know, that the standard of care in the US recommended by ACOG is that if you have a patient with pregnancy related hypertension, you follow them up after delivery within the next 7 days. Typically, we follow them 3 to 4 days, making sure that they are not getting worse. But I think in a bigger scale, we are not there yet in terms of standardized approach as to when the best time to follow up is. There are some centers that, especially in patients who have severe features, preeclampsia or blood pressure medications and stuff, they get follow up. But the real push these days is to follow these patients up at least 3 to 6 months after they deliver to see if the hypertension is persisting or if they need care, so that again, for their future pregnancies, they're better prepared, and for the long-term cardiovascular risk assessment.
Thank you for that. One other conversation in the chat is from Dr. Washington Hill. Thank you, Dr. Hill. This goes back more to the keynote speakers, but I want to answer and address. And that is how racism plays a role in the difference between the Hispanic and the Black maternal mortality and care. And one other comment he mentioned is that there was a presenter who said, we will not get rid of or significantly reduce this disparity until we adequately address the racism. And, you know, I think we all agree with that. And it's something that needs attention. Any of the other panelists want to comment on that? You know, I want to say that one research area that I'm very interested in is creating this virtual unit for the 4th trimester. You know, here at Montefiore, we had a pilot study where we tried to implement the cardiovascular screening toolkit that Dr. Hamid and her colleagues, we still have 2 minutes, have developed. And we found a very high positive screening rate, 40% in fact. This was a parallel pilot study with UC Irvine. And one of our research findings was that there was a high rate of no-show for follow-up with MFM and cardiology. And what we've learned through the COVID pandemic is that creating a virtual unit, a way for patients to be able to access care during that 4th trimester and even prior to that is something that's really needed and lacking, at least in our patient population here in the Bronx, New York.
Right, and so to add to that, what we've decided is that we would take the clinic to the patient and convert that no-show into telehealth as much as we can and accommodate the patient where they are. That could be in their car, in their home with their newborn. But we found that some of the women who weren't coming, you know, were occupied, had other things going on, and that we were missing people who really needed to be seen. So this has been a new kind of paradigm. We've just decided to go to the patient in a different way and at least then engage that person, and maybe they need testing, we can arrange and try to make it more convenient for that individual, but not to allow people to just no-show and never come back into care.
Yeah, our highest no-show rate is within 1 week after delivery. You know, it's more than 50%. And I think if there is one thing coming out of the pandemic, we're getting used to seeing patients remotely. With the timer going on 4:25, shall we move on to the 3rd case? All right, so it's my pleasure to introduce our 3rd speaker, all the way from South America, Dr. Edison Muniz from Colombia. We're delighted to have you here. Thank you.
Okay, thank you very much. And it's a pleasure to participate in this event. Our case is about anticoagulation in pregnant women with mechanical heart valve, a clinical challenge for maternal and fetal balance. This is, please, one moment. This is our institution, the San Vicente Fundación Hospital, and the Medicine School of University of Antioquia in Medellin, Colombia, and welcome to Colombia. The clinical case is about a 20-year-old pregnant woman with personal history of rheumatic fever at the age of 2 years with mitral aortic involvement, with mitral and aortic valve replacement surgery in 2008 with mechanical valves. She was pregnancy 27 weeks with insufficient prenatal care. The patient stopped warfarin for unknown reasons 3 months before she entered in the hospital, and oral penicillin prophylaxis, non-adherent, and no prenatal care. The patient arrived to the emergency room with 10 hours of evolution of chest pain. This pain was oppressive, radiating to the interscapular region, accompanied of pressure. The physical examination with blood pressure 110/70, heart rate 76, and respiratory rate 18, and the temperature was normal. The valve click was present and systolic aortic murmur. The uterine height 20 centimeters and fetal heart rate 158. This is the first electrocardiogram in this patient with hyperacute T waves in the precordial leads with a control with negative T waves, and this is dynamic changes in the electrocardiogram. The X-ray showed the evidence of previous cardiac surgery. Infectious tests are negative. Kidney function is normal, and the INR is very low for a patient with a mechanical valve. The high sensibility troponin I was very high because the percentile 99 in our institution is 45. The cardiobstetric team got together in a meeting and they defined the diagnosis of pregnant with cardiac disease with modified World Health Organization 3, non-ST elevation, acute coronary syndrome, very high risk, a possible valve thrombosis, and high intrauterine ground restriction. With this diagnosis, they decide that different actions like unfractionated heparin, antenatal steroids, coronary angiography, echocardiography, and gestational ultrasound. This test showed a coronary angiography with left anterior descending occlusion and decreased excursion of the aortic mechanical valve disc. The echocardiography showed an ejection fraction of 43% with alteration in contractility of the left ventricle, severe dilatation of left ventricle of atrium, and the presence of 3 thrombos in the mitral and aortic recesses, the measure of 12/8 millimeters, and the presence of a large calcified panus that generates severe stenosis. And the gestational ultrasound showed fetus with vitality and estimated weight 1,035 grams. This is the recommendations of the American Heart Association about the patient with prosthetic valve thrombosis. In this case, a left side prosthetic valve thrombosis with mobile and large thrombus is an indication of emergency surgery. Because the newborn was viable and emergency cesarean section was performed, the valve replacement mitral and aortic with mechanical valves, the patient needed chest packing, saphenous bridge to left anterior descending, polytransfusion was required, and hemodynamic support with norepinephrine and dobutamine. The patients received attention in the intensive care unit, and the evolution of the patient was very good. Unfortunately, the baby died. And now Dr. Velasquez continue with the analysis case. Thank you very much.
Thank you, Dr. Munoz. It's very important to keep in mind that pregnancy places women with mechanical valve prosthesis in a group of high risk of valve thrombosis. So anticoagulation should be optimal during pregnancy. The best balance between maternal and fetal health must be sought. In our cardiobstetric clinic, we follow the recommendations of the European and American guidelines of cardiovascular disease in pregnancy. In the first trimester, we differentiate whether the woman requires more or less than 5 milligrams of warfarin to maintain an optimal INR. If it is less or equal than 5 milligrams, we follow this flow chart and we recommended continue warfarin. If the women take more or equal than 5 milligrams, we recommend continuing warfarin or offers to make a change to low molecular weight heparin, always monitoring levels of anti-XA factor or use an infusion of an fraction heparin. These strategies always require hospitalization. After the first trimester, a clear recommendation is the use of warfarin. An alternative is the use of low molecular weight heparin in the second and third trimester, monitoring always anti-XA factor levels. And then on 36 weeks, we always plan patient hospitalization to make a change, discontinue warfarin, and begin and fraction heparin for 1 week, so that the fetus is no longer anticoagulated by warfarin. And then it's planned to end pregnancy at 37 weeks. All scheme of anticoagulation in pregnancy, during pregnancy, offers benefits and risk over mother and baby. However, we show that the low-dose warfarin, less or equal than 5 milligrams, offers the best balance between mother and baby, as long as this dose guarantees an optimal I and R. In our clinic, since 2016, we have treated 375 pregnant women with heart disease. Of these, 50% with valvular disease, 18 pregnant women with mechanical valves, of which 6 had thrombosis related to suspension of warfarin or anticoagulation with low molecular weight heparin without measurement of anti-XA factor levels. Our key messages are: suspend anticoagulation in pregnant women with mechanical valve is not an option. The risk of valve thrombosis is greatly increased during pregnancy. The evidence indicates that BKI treatment during pregnancy with close I/R control is the safest strategy to prevent valve thrombosis. If using low molecular weight heparin, and a strict control of anti-XA factor levels is required. And this is the most important conclusion. A pregnant woman with mechanical prosthesis should be handled by experienced cardio-obstetric team. And this part of our group that is composed by nurse, anesthesiologist, social worker, obgyn, cardiology. And thank you for inviting us to this fantastic event. Thank you.
Thank you, Dr. Velazquez, for such a wonderful presentation, and congratulations on your teamwork. What a case. This is, a cardiologist and MFM nightmare that you were able to successfully manage. I'm sure we have a lot of questions related to the care of such patients. I thought about team building when Dr. Hamid and Dr. Silversides were talking about this program, and there are a lot of stakeholders in this team. And if you talk about teams, other people might say, okay, there are too many cooks in the kitchen. Now, we definitely need to clarify roles and responsibilities, and who in your team is taking the lead to take care of following up the anticoagulation management. MFM, cardiologist, hematologist, or social worker, or anybody. So let us know your strategy to identify that lead person.
Okay, this is a good question. It is very important for us the teamwork. Then we need the participation about the different specialties in this case. It's very important for us the patient participation. For example, the patient needs to know the different options, never of the option of the anticoagulation In this case, it is perfect. All the options are very difficult because you can help the patient, but it's bad for the baby, or is good for the baby, but is bad for the mother. Then, in this case, we participate with the patient, explain them her about the option, the risk, and with the nurse is the very important in this case for the education for the patient. Explain here about the condition, the different options, and with the nurse, the cardiologist, and the obstetrician defines what is the most important option for this case.
Dr. Velazquez, do you have anything to add?
You're on mute.
Okay. I accord with Dr. Munoz. The major decisions we take both or team.
I have a question. Have you thought about thrombolytics in this kind of patient?
It's difficult because in some cases the thrombolysis and the pregnancy is relative contraindication, but is an option in patients with valvular thrombosis. In this case, but mobile and large thrombus, the team defines the needs of the current emergency surgery with emergency. But in some cases, like some cases that the patient have a privative risk, an option is a thrombolysis.
Great, thank you. I see Dr. Harrison has a question in the chat. Dr. Harrison, would you like to ask a question?
Yes, I was asking about the goal of anticoagulation when using low molecular weight heparin in this setting. The conventional goals do not leave the patient controlled, and when they're at the trough level, I think there's El-Kayam articles that have shown what the trough levels are. And I'm wondering if what level they were attempting to maintain when using 10A and anti-10A levels, and if anyone has tried using the El-Kayam strategy of maintaining the trough therapeutic.
The anti-10 factor for us is very difficult because in our country is not possible that take the test in many hospitals. But in some cases, where it's possible for us, we take to the test, and the number, the goal in these cases are 0.8 or 1.2, the goal in these cases. 0.8 to 1.2.
Thank you.
There is a question in the chat that I'm not sure I understand the abbreviations. Maybe our cardiologist here can help us. It's from MM, one of the attendees, who asks, how safe is the use of NOACs in patients with DVT, AFib, and pregnant? I'm not sure what NOAC stands for.
It's a novel anticoagulant.
Oh, thank you.
So in general, these are not used in pregnant individuals. Instead, what would be used are things like Lovenox, low molecular weight heparin.
Okay, the new anticoagulants and the pregnancy are contraindicated in all scenarios and in the valvular mechanical valve is more now. It's a absolute contraindication than new anticoagulants in patients with mechanical valve and in pregnant in both cases.
Yeah, I agree 100%. You know, it's not proven, and you know, the use of NOAC or DOAC, however you say it, is not proven in the setting of pregnancy, particularly in the setting of mechanical valves. More data is coming out in some of the mechanical valves that requires lower levels of INR. Onyx valve is being tested, but not in the setting of pregnancy. So we'll see the result probably in a few months to come.
There's another question in the chat from Dr. Brian Latzman. Did you consider an approach for the patient with PCI of the LAD and IV heparin for the valve thrombi? Would that have been another approach? And I'll direct that.
Sorry, I don't understand, please.
Sure. The question is whether or not you could have a percutaneous coronary intervention for the LAD lesion. This individual had a saphenous vein graft to their LAD at the time of surgery. So the question is whether you could have placed a stent in the LAD and treated the thrombi with intravenous heparin, for example.
Okay. The question is very important because the case the patient needs and different interventions. But in this case particularly, the patient has 3 thrombus with a large and a mobile in one case, but in the mitral valve, the patient has a pan with a great calcifications with severe stenosis. But for these conditions, that team defined that the most important treatment in this case was the surgery.
Thank you. I think with this, in keeping with our time, I'm going to turn the floor back to Dr. Wolf.
Okay. Well, you know, this is the conclusion of our symposium, and you know, I just want to thank all the participants, the speakers, our presenter. Each case presentation was fantastic. Murakoze, grazie, gracias. Thank you everybody for being here. And to our team here at Montefiore Medical Center for formulating the symposium, and for our departmental support from both OB/GYN and Women's Health, as well as the Division of Cardiology, Department of Medicine. What I would really like is to ask each panelist to make a comment on where they think the field of cardiobstetrics is going post-COVID pandemic. What is our next step, our next approach, and next goals? Can we start with Dr. Silversides?
I'm not sure. So obviously the most obvious thing is figuring out how to use virtual care to improve care in general. I think that's the most clear thing from the pandemic, which has already been alluded to. But where cardio-obstetrics is going on a bigger scale, I think you would break it down. I mean, I do think we're moving to really educating the new crowd of MFMs and cardiologists, just as I've already alluded to, with how guidelines are starting to make their way into medical education. I think research, there's a million different things we could talk about with research and where it's going to go over the next 10 or 20 years. And And I do also think we're going to start finding innovative ways to provide better care with this whole idea of this really unique interdisciplinary field. And it's not just us. I mean, valve heart teams are doing the same thing. There's a whole bunch of fields in medicine that are really, developing this team concept. So I think that's to come too. I think, we've been kind of floundering along putting together teams, but I think we're going to get it really spot on at some point of how to really streamline this team approach to care, because I think we're good, but I think we can do it better. And then my last thing I would say about cardio obstetrics is, all of, or many of us that are speaking are in tertiary care centers, but many of the things that happen, so for instance, that study I showed you that we did looking at life-threatening events, they don't happen in tertiary care centers. They happen in smaller hospitals. And so I do think we're going to have to figure out how to target getting all this knowledge out to different care providers in different settings. And we've only again just started to figure out how to do that, but I think that has to be a focus in the future, because there's a lot of things that don't happen at our big centers that need to be addressed.
It's a really good point. Dr. Hamid.
Yeah, I agree with Candice, all of the points that she made. I see this, I've never seen as much interest, particularly from cardiology fellows, young cardiologists who are more interested in knowing about pregnancy. So, and likewise in MFM side of things, we are seeing MFM fellows who are more interested in critical care or cardiology. So I think over time, we are going to see this super specialized group of cardiologists and MFM who are going to be managing these patients. And as alluded to earlier, we can never have 100% of cardiac disease and pregnancy funneling to big university hospitals where we are located. So there's a need to have a process in place. It doesn't mean that you have to have MFM cardiologist there, but it basically is going to be a structured way of diagnosing, referring, and transporting patients to the appropriate care facilities. That is what is needed. I think that is going to be the push from various stakeholders through the country. And each one of us, no matter where we exist in terms of our practice, we look around and see what kind of patients can we take care of, what is our resources, what level of care we can provide, and when do we send these patients out. And then, of course, one of the biggest things that we have learned is the virtual consulting and seeing patients, telemedicine. I think it's going to be a great role going forward, especially on those remote areas where the MFM or the cardiologist can talk to the midwife or the OBGYN there and guide them through. So I think there's a lot that is going to evolve over time, and I'm very excited, and we are hopeful that we can take much better care of these patients. And again, I'd like to congratulate all three presenters from all over the world. You guys are doing a wonderful job with limited resources, and especially the last one where the mortality is so high with a patient who had valve thrombosis. So congratulations on saving the life. And I think, and another thing that I feel really a good things thinking about 2020 as we are approaching the end of 2020, hopefully the end of COVID, is that we have somehow come together more. I think all of the different countries, like we are sitting here, we are in different parts of the world, but we are actually sharing our experiences. And this is, again, a great way of disseminating information, gathering information, and sharing as we go along. So everyone, stay safe. Thank you so much. Thank you so much for having me.
Thank you. What about Professoressa Chetin? You know, you've in Milano, you guys have really been on the front lines. And where do you see this going post-COVID? Magari.
Yeah, well, first of all, when this patient that we presented had her case, it was 20th of March, and that was really very, very bad period for Milan. And that's why the first thing we thought was COVID, you know, but she didn't have it. So anyway, no, this period is, I mean, I agree with what everybody else has just said. I think that apart from this, we have really to use these cases to learn. All cases, those that die, obviously, but also the near miss cases where we have always to discuss them with between ourselves, with our residents, with the cardiologist, with the anesthesiologist. I think we have to be. I think we are changing and we are making it better for pregnant women. I think. I mean, I know that the data in the US for mortality are rising, but in Italy instead, we are doing better now. I mean, maternal mortality in Italy in northern Italy is around 3-4 per 100,000. So it's very, very low now. But we have a lot of near miss cases and we do, I mean, we try really to investigate the causes. And I think this is what we have to do, you know, to try to be learning. I mean, each case is teaching a lesson. This is what I think, really.
Thank you.
Thank you very much.
I wanted to ask Dr. Su, you know, when Dr. Silverside said that the congenital pediatric patients are becoming the adult patient immediately, made me think of Dr. Su, who's a congenital cardiologist, pediatric and adult, which you know, I think is extremely unique. There's not so many in this country. Very important. What are your thoughts?
I think raising the awareness of community, the pediatric community, that these issues are coming down the road is very important. And so I'm counseling. I think that we don't do a very good job even in our complex congenital population of talking about pregnancy, and we need to do this so we can prepare our girls for the future when they become women. And that's a goal that we should achieve together with pediatric cardiologists, adult cardiologists, obstetricians, to make it much more standard about the next phase of life with our patients.
Yeah, agreed. Thank you. Dr. Taub?
I think if I reflect on our journey in 2020 and thinking about 2021, there's one word I would like to summarize is alignment. Align patients' need with our cardio-obstetrics team's effort. Align the membership, you know, within the cardio-obstetric team's effort with each other, and importantly, align the team in the trenches with the institutional leadership's vision. You know, I think, you know, at this meeting, I would like to take the opportunity to thank our leadership at Montefiore, Mario Garcia from cardiology and Sharmila Makija from obstetrics, supporting us with human resource, with financial resources to make sure that our endeavor is funded and we're moving forward. And I hope a lot of success in the future for our Montefiore cardio obstetrics team. Thank you.
Thank you, Dr. Bortnick.
Well, when you asked me to reflect on 2020 and where we are, I'm really thinking about policy. I had CNN on in the background and I heard our outgoing Surgeon General, Jerome Adams, say that we cannot truly improve maternal health until we acknowledge and address the disparate outcomes many women of color face. And he caught my attention because he was talking about maternal mortality, and he's talking about it you know, from the level of policy. That's where we need to be. he has several goals that he had set out to reduce the maternal mortality rate by 50%, to achieve blood pressure control in 80% of women of reproductive age with hypertension. And many of these women are living in rural areas and are women of color, and we need to reach those women, in addition to women in our urban areas who are have other family issues, obligations, who are new mothers, for example, who are working. So we have to reach women where they are and educate and treat them. This is what I've been thinking about at the end of 2020, is about policy and how that's going to be important in fixing this issue of maternal mortality in the United States. And I think we can learn from the examples of our colleagues around the world as to what is working with their systems, other places, the different criteria that were brought up today, the different approaches. We should try these things in our own system to combat the problem.
Thank you. Dr. Harrison, do you have anything to add for a future post-COVID?
Not so much, especially post-COVID per se, but I think that the outreach to find the patients that we need to evaluate before pregnancy is key, and that the promoting preconception to cardiologists and family practice people and medicine people to get patients into care and evaluated. It seems to me that I'm on the New York City Maternal Morbidity Mortality Review Committee, reviewing all the deaths in New York City in women who are pregnant or in the first year postpartum. And I think that we've already seen from some of the numbers here today how many women have a pre-existing condition that predisposes them to this. And I think the gap between what medicine people know or family practice people know or pediatricians know and OB makes it less likely that we're going to see these people and evaluate them. I think having a preconception, a place for preconception care, and I applaud your clinic for making available the combined care between OB and cardiology for both preconception, antepartum and postpartum care for women across that whole spectrum. But I think we're missing people who we just don't, we don't know, we don't get our hands on people to get them into good care early enough. And that'd be my big push going forward.
Yeah, that's well said. And, there's the patients who we don't discover until they're really sick. And those are the really difficult ones to capture. Although with the cardiovascular screening toolkit, that's suggested to really conduct with all pregnant patients and all postpartum patients, we're hoping to capture more, but that requires a lot of work for a great number of screens for, we don't know how many we would actually capture, but more to come to tighten up that algorithm. So thank you. Our time is up, but any last comments? So I did put my email in the chat for anybody who would like to email me. I can keep people in touch with one another or help answer questions. And this is also going to be available on YouTube on @MontyHeart. So you can share. And thank you again to everyone. Here in New York, there's a snowstorm, so everybody get home safe, whoever's here on this side. Maybe in Medellin, you'll be going to the beach. I don't know.
Thank you, everyone. Great to see you.
Thank you very much.
Thank you.